Originally a flight nurse from BC, now working as Director of Operations at Airlift Northwest in Seattle, as we learned yesterday. He spoke to us, reminding us that good interprofessional teams, there needs to be no hierarchy. We need to train the way we will do it in reality, and that different interprofessional team members bring different organizational perspectives to the systems and structures that we work in. So we welcome you up. Thanks, Kyle.
I love this idea because I just budgeted for like a $70,000 simulator. And so when it gets shot down in the budget, I'll know what to do. I appreciate that. So, and I think I'm going to offer hopefully a complementary approach to what we discussed about what we do at Airlift Northwest. So it's very specific to Airlift and the context that we're in. I want to talk about really the philosophy behind what we do, some of the tools and technology, and then the culture that makes it all possible. I'll be repeating some of the stuff that other speakers have, so I'm going to actually skip over some of those parts because I think that way it'll leave some more time for discussion. So the challenge we had at Airlift, so I'm going to kind of take you through a journey over like the last 5 years, and I should also mention at the beginning, I'm presenting the work of my team, right? So I've got a great team of educators. Matt Plord's our Director of Education, one of our Assistant Chiefs, Michaela Hagberg, really put this together with, we have a group of 9 educators. So, but what we found was that like the education, safety, quality, and operations, they were really all operating in their own silos. And this is probably not unique, but it is a solvable problem. So with that in mind, we wanted to see kind of how these things could come together. But before we do that, I just want to talk a little bit more about Airlift. I mentioned it yesterday. We are geographically dispersed. So we have a base up in Juneau, Alaska, as I mentioned, and then we have 8 bases altogether. But if you have 150 providers and you're spread out across this distance, you know, the way you deliver education is different, and it's costly and it's challenging. So as I mentioned, I think we're both rotary wing and fixed wing, and we do about 43 to 4,500 flights a year. I think as we think about teaching and training for excellence, it really starts with the people that you hire and that onboarding process. And so I'm going to spend some time talking about that. But the nurses, the flight nurses that come into Airlift, they've all got experience at least 5 years, some closer to 10 as they're entering. Lots have specialty backgrounds as well, like whether that's, we were talking about ECPELAs earlier. We are definitely attracting more nurses with that cardiac assist device training, ECMO, and pediatrics and neonatal care. But I think the people that are most successful have a mix of experience. And so if you've done pre-hospital, even if it's, wilderness first aid, to come and work in the pre-hospital environment at Airlift, that really sets you up for success. So thinking about the philosophy of how we do things, it was trying to integrate what was previously silos. So, our education priorities were being identified. I'm going to show you how we actually do that in a minute. And then through the clinical competencies being built, we've got improved outcomes and this sort of regeneration of data. So we had to pull all these things together which really started with a quality plan. So putting things on paper about how these things are going to work together. If you have a safety management system that has to feed into what goes into education, because what was happening and might happen in some of your organizations is that training started to become the result of like the last really bad call that happened, right? Or the most extreme case. And that sort of recency bias, it really fell out of sync with what was actually happening in the world at Airlift. So you're doing 4,500 flights a year, but you're training to the 25 really bad ones that most people are never going to see again. So that was a change for us, and really the philosophy of the education department changed from, and forgive me for the Star Trek reference, but like the Kobayashi Maru of simulation, like the unsolvable, you're never going to get through this simulation, to one that really matches up with the environment that you practice. And so what I'm sharing with you here is just that how they prioritize curriculum and that core curriculum. And so while we have those rare high acuity procedures, for the most part, we're looking after really sick people in interfacility transports. Airlift does about 70% interfacility transport, 30% scene responses. So training to those core competencies in, cardiac care, respiratory failure, neuro, major trauma, airway management. That's like the bread and butter of airlift. So whereas we also had some high risk areas, and those are our special populations where we developed education around, so we didn't want to forget about that. But we really dropped out of prioritization the low frequency, high acuity ones. So it still happens, just not, it was all about rebalancing. So building from the ground up, I think as we think about MedResponse BC and other organizations growing their programs, I just wanted to share how we do things at Airlift. And we start with a flight academy that is actually in a transition period. We used to do like a 3-week, drinking from the fire hose and then out to the field. And it's changed in the last 2 iterations to more of a spend about a week here and then actually to the field right away, coming back in for didactics every week. And so they do that for about 12 weeks, and then they're supported as they transition into practice. And I'll talk a little bit more about that. There's evaluations, of course, along the way, and then there's like a 6-month refresher and some test outs at the end. A big part of what we do to keep everybody safe is that we don't pair up what we call green on green. So new people don't fly with new people. And so while there are recommendations, there isn't a set standard of what that means, and we're even having conversations now about how that has to change. So 1 year is really the mark for a green flight nurse. So before that year, you're not going to be flying with somebody else who hasn't been flying for a year. But if you're coming into Airlift and if you've got 5 or 10, we just hired somebody with 17 years of flight experience, that person maybe only needs 6 months. And so we're really trying to be a little more nuanced about what that need is. And even though we did swing to the 6 months for previous flight providers, we realized that I think as you mentioned earlier is like, you've seen one rural community, you've seen one real rural community. It's very similar in air medical, and so that 6 months might be a little bit on the low side. So we're constantly trying to reevaluate that. But what this means to me is that, when you're a flight nurse and you show up for your shift and you see who you're working with, that you could go out there and do everything. Anything that comes, at least you're prepared to deal with it. And preceptors are a key part of that success. And so we've really developed a more robust way of supporting our preceptors, those people that you'll be working with as a new flight nurse. And so they're getting dedicated training days where we're talking about a lot of the concepts that we've gone over today for crew resource management and communication, how to give good feedback so that people can learn and grow. Also identifying some of those early warning signs that somebody might be really struggling and how to intervene and support them. And then linking up those people that are in the field out there doing the training, if they get past the tea room to do the training, then how does that feedback from what's going on in the field get to the education team? So we've got some tools I'll show you here in a second. Other things we do to support people's ongoing learning for some of these high acuity issues, we have what we just coined like Airlift University, but it's an online repository of all the training and things. So if you want to brush up on a particular skill topic, it's Airlift curated stuff that you can go to daily. We have alternating safety and education training that follows all of our staff meetings throughout the year. So there's that spaced repetition, but also coordination of everything that's going on throughout the year. We have what's called competency days, and I'll talk a bit more about that. But this was new to Airlift 5 years ago, and it honestly didn't land well to start with. People were like, hold on a second, I've been working here for like 25 years, and now you want to test me? Like this wasn't going over well. But we had to show that it wasn't about testing. This wasn't a punitive experience, and reinforcing the concept of good, just culture that we talked about. We also listened to the nurses, and taking the spin off of Fight Club, they developed a Flight Club for those case reviews and things that they did want others to learn from. So other people, if they found themselves in those cases, could learn from their mistakes and their learnings in the field. We've also developed podcasts and a journal club. We also have dedicated survival and safety training, water egress, safety training, all the usual stuff. But another, I think, thing that makes us successful at Airlift is our academic affiliation. And it's something I'm really proud of. It's helped me be a better clinician. Having access to be able to go into the hospital so our nurses can go into the units, ICU, ED, pediatrics, that sort of thing, and work alongside the attendings and associate medical directors of Airlift Northwest in the clinical setting has been tremendously helpful for our staff. We also do live intubation training with anesthesiologists at Harborview and at Seattle Children's, so making sure we're getting both those patient populations. But that's also very resource intensive. You're bringing people in from across all of that distance I showed you earlier. Is not, that's upwards of $250,000 a year to pull something like that off. So we are looking at other options, cadaver labs, that sort of thing. And I'll talk about the real-time consult with adult and pediatric medical directors. I think that's a focus of this conference, is how the interprofessional part, but that's also something that makes us successful. So the next photo is one of our actors. So the question I ask is like, how well does your training environment match your practice environment? And so this is the other extreme, which is, and when I think about what are we optimizing for, it's in cases like this, it's not so much the skills for managing the obstetric hemorrhage, but it's also those teamwork skills. How do you deal with the husband who's screaming about their dying wife, or you have a belligerent referring provider in your face. That's what our team has to do in the real world. And so we've found opportunities to inject that into our training, and have found it to be very effective. So live actors can be actually a really helpful training aid as well. It helps you sort of get exposed to that cognitive stress and things. But just to tie into earlier talks, we actually, when you're hosting a simulation, they'll give you a minute. They'll say, all right, this is your call. You got a few minutes. You're going to do that mental visualization as a team before you jump into it. And I'll talk a little bit about the debriefings in a minute. But how to practically pull this off, you've got 150 providers across all this space. The team developed their own app for doing the simulation checks. And so giving the evaluators, if you will, the training to how to fill these out and collate that information. And this isn't for you to be able to read any of this, but just to kind of show, all that information ends up in a database that allows you day of in simulation, like during your sort of group debriefs, to realize something's really being missed here. And then it also aggregates into a larger system-wide performance KPI sort of benchmarks to look for other things that you might want to address in future training. Or one of the things the team often looks at too is what they're seeing in simulation actually happening in the real world, and is this just an artifact of simulation? And I think that's an important question to ask. A few times that we've checked that, we've realized that actually whatever happened in simulation caused them to miss a particular assessment or treatment that is actually being done in the field. So just questioning is what you're seeing in simulation the same? And having an integrated quality program, like I mentioned earlier, is the way to be able to do that. If you're doing education in a silo, it would be impossible. So one of the things that I suggested to the team, and I'm glad they took it up, because was how we do the debriefs of simulation and of the training. So it's I'm sure it's common in other organizations, but when you set the skids down, or the pilot powers down the plane at the end of the flight, nobody gets up from their seat for a minute, and you're going to have a quick chat about how things went. Anything you want to do different next time? What could we do better as a team? And when you're doing 4 or 5 flights a day, that's, as I've heard several times today, that's just how we do things. And that's part of the culture that makes this successful. So I said, why don't you incorporate that into the simulation training? Because that getting over that hump of at the beginning of people feeling like they were being judged and punitive, and somebody mentioned earlier about that, people are, I think it was Dr. James pointing, we're able to point fingers at ourselves. Well, let's give them the opportunity to do that. And so at the end of the simulation, giving people a few minutes to just discuss for themselves what they thought. And they'll say, oh yeah, well, I missed this second thing on this part of the guideline, or oh gosh, I wish I did this first, or I gave the herniation stare and I apologize for that, or whatever it might be. So a lot of growth has come out of those conversations, but it's really built on a foundation of just culture. So having that space and psychological safety where people can have those conversations, knowing that they'll be supported with education. So as I wrap up, I want to mention our integration with our medical control physicians, because Airlift Northwest while we have clinical operating guidelines, and you can mix and match those for the clinical situation without consultation, if you want to operate outside of that, or if your patient's in extremis and you want a little extra help, we have medical control available 24 hours a day. So you're also teaching and learning in that moment. When you have the same docs that you trained with at the hospital, who are your medical directors, who are at your simulation training, and you call them in the middle of the night, it doesn't take you long to get in sync with them, right? You can quickly convey the situation and how they might be able to help you. So you're learning in that moment. It's also not unusual, because we're taking them to some distinct hospitals, is that you're going to see that doc when you drop the patient off and have a quick huddle at the side of the bed and say, hey, is there anything we could have done different in this case? Anything you'd like to see different next time? And so you get some learning and some reinforcement there. So, and then our medical control docs, we've got a series of associate medical directors who follow up on charts. And so you're going to get a review of that call again, maybe in a week or so, once they've had a chance to review it, of giving you some critiques on your flight and how things went. And sometimes I think that feedback can be a little hard to hear, but it's also helps the team grow, and everybody appreciates that. And having that trust, as we've talked about, being built all through these steps, that lands a little easier with you when you do get it. So in wrap up, I guess what I wanted to kind of tie back to earlier is that this is one of the hardest jobs in the world, also one of the most rewarding, but what we want to be able to do is prepare people to be successful for the work that they're actually called to do, and so that they can have some resilience. Airlift Northwest is like a lot of organizations that are like this, that people come to Airlift and they stay for 25, 30 years. But to do it that long, you have to have a system that supports your resilience. So with that, thank you.